Great. So, hello, I'm Jeremy Isaacs. I'm one of the members of the BMPA committee, and it's my great pleasure to chair and introduce the first two sessions in this morning's programme. I'd like to start by welcoming Peter Garrard to give the first talk. Peter is Professor of Neurology at St George's, University of London, which you all know is the best university in the world. And he has a distinguished career analysing language as it changes before and during dementia. And you may remember that, Peter, you hit the headlines some years ago by doing an analysis of the works of the late Iris Murdoch, showing how her writing changed with the beginnings of Alzheimer's disease. And in these opening remarks, Peter's told me he's going to judge me on my adherence to the four domains of language, which are motor speech, semantics, syntax, and phonology. So I hope that in these off-the-cuff remarks, I've adhered to those domains appropriately. So Peter, you're going to talk to us about detecting and measuring language change in neurodegenerative disorders. Thank you.
Jeremy, thank you for that kind introduction. Thank you, Boyd and Jeremy and the committee for asking me to open the batting here today, albeit brought in from the benches after Henrik Zetterberg cancelled or something, or maybe was injured. Anyway, I was hoping to say that I'm going to be more like Harry Brooke than Geoffrey Boycott. But then I saw his wonderful diamond duck the other day. But I certainly won't outstay my welcome like Geoffrey, Robert, for your talk. So, detecting and measuring language change in neurodegenerative disorders. Here's a profile of a typical patient or notional patient with dementia who potters along, pootles along quite nicely for a few years and then starts to decline. And then a few years after that, he gets a diagnosis, and then he continues to decline in the absence of disease-modifying therapy, although that might be about to change until he eventually dies. And here's the what is now thought commonly to be the trajectory of the underlying pathology, be it Alzheimer's, tauopathy, TDP-43.
Can we make the slides advance on the projector? Oh, you need to use the clicker.
Oh, sorry, yeah. Okay, sorry. I can see them here, fine, I don't need this. Here's the notional profile. The patient poodles on quite nicely. He's not quite right here, usually recognized by the family, usually retrospectively. He goes to the doctor. After months or years, he gets a diagnosis. In the absence of disease-modifying therapy, he declines until death. And here is what is regarded as the underlying pathological change during this period, and it doesn't matter whether this red line is Alzheimer's or tauopathy or TDP-43 proteinopathy, but it gradually accumulates, initially causing no symptoms, and then at some point, probably around this point where the patient's family notice that they're not performing as well as they ought to, the effect kicks in, the cognitive reserve is exhausted, and the pathology and the cognitive profile, the cognitive performance decline, not quite in parallel, but certainly together, one causing the other. Now, as said before, disease-modifying therapy doesn't work, and one of the reasons for that is thought to be that we don't treat it early enough. So this point here, the diagnosis, or even this point here, mild cognitive impairment, probably isn't soon enough to cause any great impact on the clinical progression. So the search is on for ways of detecting this period here, the period when retrospectively the family look back and say, yeah, God, 2 or 3 years ago he was repeating himself occasionally or making these funny errors in speech. And of course we could do this because the pathology is there. We could do this by doing an amyloid PET scan, a lumbar puncture, or we would have heard from Professor Zetterberg blood tests. But these are all expensive. We couldn't really do them on the millions and millions of people who would fall into this category. They're painful, take a lot of time, and they're also expensive, and they're not quite there yet. So there's a lot of, and has been for a while, a lot of attention paid to the fact that language changes early in AD, and language is quick and easy to sample. You don't have to do anything, really. You just make the patient speak, have a conversation with them. In some ways, it's like taking a mental blood test. Language depends on a large network of brain regions. So there's the hit rate, or the likelihood of the underlying pathology targeting one of these areas and causing change in language is quite high. And of course, language change, as we know from, as Jeremy mentioned, language change precedes the classical symptoms of AD, the memory and the visuospatial impairment. And we demonstrated this long time ago by looking at the novels of Iris Murdoch, and found that her word frequency changed in her later works, and the rate of introduction of new words, the progressive type token ratio, the cumulative lexical diversity changed in the three novels, was different in the three novels as well. The bottom one tailing off in its introduction of new words, while words were being introduced at a higher rate in the earlier two. And this was also found by Barisha and his colleagues in 2015, when they looked back again, retrospectively, at the press conferences of Ronald Reagan throughout the years of his presidency. And they found a decline in the use of unique words in those extemporized speeches, and they also found an increase in the bottom panel. In the bottom panel, an increase in the number of non-specific nouns, generic phrases, generic words like thing and stuff, and fillers, which I use a lot of as well, but I always have. So language is also susceptible to rapid and automated analysis, and it can be used to train and interpret machine learning classifiers. And we can extract from it, in the manner perhaps of a mental blood test, various variables such as lexical selection, sentiment. You can automatically analyze sentiment, topic, what they talk about, the complexity of the sentences and phrases, the number of words that they use to express an idea, which goes up in Alzheimer's disease, as was demonstrated by that wonderful Nun study that was done in the 1980s, information and accuracy. And my PhD student, Natasha Clark, plotted these from a set of AD and MCI patients, Alzheimer's disease and mild cognitive impairment patients, and healthy controls, and found very different profiles. And this is not real data. This is to illustrate that various machine learning classifiers, support vector, etc., can be used to, can be fed these variables and predict whether somebody falls into the AD or MCI group or the healthy control group with various degrees of success. And more recently, we have these unsupervised convolutional neural networks, or deep learning models, where we don't need to extract the features. The network does it for us. The patient just speaks or phones in, and the class, in other words, AD, MCI, normal control, is output at the end. And this has been particularly picked up by a group called Neuroic, which is led by a couple of neuroscience entrepreneurs, Emil Fristed and Jack Weston. And their current model, as you see, isn't perfect, but it certainly picks out the people with MCI or AD, where the diagnosis is made on amyloid positivity with pretty good sensitivity and specificity. Now, I'm going to here go off-piste and say that I don't think that AI is the answer to, even though a lot of what I say and write has said that that AI is one of the ways forward. I don't think that AI is the answer to everything. Somebody said that AI is smart until it's done. In other words, it can do lots of things, and then suddenly you find that it's telling you a lot of garbage. And this gives rise to a high risk of false positives, which is not what you want in making a diagnosis of an untreatable disease. The black box solutions, in other words, the kind of thing that I'll just go back, this kind of thing, where what goes on in here is pretty much uninterpretable, not completely, but pretty much uninterpretable, doesn't really tell you very much of interest other than what class the speaker is in. I don't know why I put mission creep there, but the patient experience is important in any clinical interaction, which is why I've developed a degree of skepticism about these approaches. And the clinician experience too. No clinician wants to be replaced by a computer that either says yes or no. And in fact, in the clinic, most real language disorders are fairly obvious to the trained ear. We don't need a convolutional neural network to tell us that somebody's language is not right if we have our ear in the clinic. This is particularly true of the three classical syndromes of primary progressive aphasia: the non-fluent, where the speech is halting or stuttering or agrammatic or fragmented; the fluent, otherwise known as semantic dementia, described by somebody in this room, who we'll hear from in the afternoon on a different topic, where the speech is well-formed but empty. The patient uses a generic vocabulary, they circumlocute a lot, and they can't understand the meanings of the words you tell them. And then this slightly sort of hybrid group of the logopenics, which remains slightly controversial, where their output is sparse, they have a degree of word-finding difficulty, they make occasional errors in pronunciation, but they do have this marked difficulty with sentence repetition due to auditory verbal short-term memory deficit quite early in the course, which distinguishes them from these two. And the MR atrophy patterns are different in these three. Mary-Lou Gordo-Tempini and a group of her collaborators published this table of what the formal differences on testing would be between these three variants, if you bothered, or if you had the time and resources to look for each of them. And I won't show this for very long because it's giving me a headache to look at it, but essentially, if you did all these tests, then you could probably distinguish these three primary progressive aphasia variants from one another with a good degree of reliability. But we need something more brief. That's a grammatical error. We need something briefer than that. Some colleagues in Cambridge and Manchester and I came up with the idea of putting together a mini linguistic state examination to be used in the clinic, no need for referral to the speech and language therapists or neuropsychologists. So this was a clinic-based language assessment instrument. And instead of measuring how well people did on various tests like naming or fluency or single word comprehension or repetition, etc., we introduced this idea of using their errors and seeing whether, in what domain, what of these 4 domains that Jeremy mentioned at the beginning, phonology, motor speech, syntax, and semantics, in which of those domains their errors emerged. And we developed this simultaneously in English and Italian because people think that everyone with primary progressive aphasia speaks English, but of course they don't. And we validated the test, and it's now published. It was published last December in Brain Communications. Teams from St George's, Cambridge, Manchester, and Pavia, Stefano Cappa's group in Pavia, validated it in English and Italian. Now, the mini-linguistic state examination comes in an A5 book format. It opens up so that the stimuli would be at the top of the page. I'll show you on the next slide, facing the patient, and the clinician has a scoring page in front of him. And we came up with 11 linguistic tests or assays, and we just the tester spots and marks the error types that are made on each of these assays by the patient. And the score is calculated by using the numbers and the types of errors across all the assays. So here's an example, the first test, naming. Name these pictures, and the error types, or if they get it correct and say squirrel, the error, they get a tick here. If they say something like, it's one of those little animals that ruins your garden, then they might get a point deducted as a semantic error. If they make an unpronounceable, something unpronounceable, they would get a motor speech error. If they say something that sounds plausible but isn't correct, they would get a phonological error, and so forth. You can't make a syntactic error. You can't make a working memory error on this particular condition, but you can on others, as we'll see. And here's an example of word repetition. So they say these words that are difficult even for unaffected speakers to say, such as chrysanthemum, and we try to make them then point to the correct referent, and this is quite difficult for non-gardeners, which means that in a lot of the tests we deliberately made it difficult so that we would avoid ceiling effects. And so you go through these 11 linguistic assays, you mark off the errors that they make, and then at the end you total them up. The errors could be how many motor speech errors, how many phonological errors, how many semantic errors, how many syntactic errors, how many working memory errors they made. And you calculate the score here using the total number of errors subtracted from the total number of correct answers. And you get this nice 5-dimensional profile, which, generally speaking, if you apply this, I'll come back to that. If you apply the algorithm that I'll show in a minute, or the decision tree that I'll show in a minute, come up with the classification between these 3 variants. And somebody's obviously going to say at the end, I'm going quite fast actually. Somebody's obviously going to say at the end, oh, what about the mixed cases? And I'll answer that question when it comes up, because it always does. But this test was validated on people whom, pretty good, generally John Hodges trained cognitive neurologists said, this is a semantic dementia, this is a primary progressive non-fluent aphasia, this is a logopenic aphasia. So the machine learning that we then applied to the MLSE had this as its gold standard. And they're going to be people who fall in between the cracks, obviously. But if you think about it, that doesn't matter, because those people are described in this kind of novel currency well, not novel, but a new way of using a common clinical currency to describe the deficit in somebody's language. And obviously that's going to change over time as well as they go through the stages of these different conditions. So the advantages of this are that actually anyone can administer it. It's not difficult. You sit there, you give them these instructions. What are these pictures? You know, which one is the chrysanthemum? You can read out a complex sentence and get them to point to one of 4 pictures, which is the correct depiction of that, like the test for the reception of grammar. Any clinician can do this, and it just takes, I say 15 minutes, it's probably, average is probably more like 12. So it's brief, and it can be done in the context of a clinic appointment rather than waiting for the speech and language therapist or the neuropsychologist to report back. Using these gold standard classifications from John Hodges trained cognitive neurologists, we found that the MLSE classified cases in more than 90% of cases. That's to say, put them in the correct category. When it was a case of saying, are they a PPA or are they a control, it was much, much higher. It was 97, 98%. And here's the decision tree that the machine learning model that we applied to these data came up with. I won't dwell on it, but essentially it enables you to determine whether, given the feature, domain, rather performance on these 5 domains of a patient, whether they fall into the non-fluent, the semantic variant, or the logopenic variant, PPA. So as I've said, we validated it in patients with both primary progressive aphasia, and we've also got some data on post-stroke aphasia. And in the former, we have an Italian and an English version. And that bilingual development in the development stages, having Stefano and his team on board, facilitated the creation of parallel versions in other languages. Now, some of the problems with the MLSE, it's quite bulky to carry around. It's one thing to carry a sheet to do the MMSE. It's quite another to carry this A4 booklet around. And also, when you're sitting in front of the patient scoring, he or she can see you scoring, which may not matter, but you know, it would be better if not. It is actually difficult to know where to file it after completion. I've got all my tests in a filing cabinet in my office, which probably violates some law or other. But it would be difficult to put them in the patient's notes, but particularly because they're all electronic these days. And the scoring procedure, this kind of going through and saying which he made that error here, he made another error here, and then transferring all the numbers, adding them up, and putting them on the final page of the booklet is a little bit clunky. And some of the error classifications can be difficult, so people wouldn't always agree on whether somebody made a phonological error or a motor speech error. And that's something that needs to be ironed out as well. But most of the time, the classifications are agreed on. So we then went on to develop the web app format of the MLSE, the eMLSE, which is in its pilot phase at the moment. And this is run on 2 machines, internet-connected machines. The patient sees the stimuli up here, one at a time. The clinician adds the scores using a second device and also controls the appearance of these on the screen. And the score and the profile are just generated automatically at the end of the test. And that decision tree can also be applied, and if they fall into one of the classical categories, then they would tell you that as well. And data obviously can automatically be stored in an electronic record or in a research database, or preferably both. And then we want to, the next stage, develop the intelligent MLSE with decision support built into it, which associates sounds with the correct error types, again using gold standard classifications from John Hodges trained cognitive neurologists and the people that we trained as well. You need obviously a machine learning classifier development for this, which we're engaged with, and you need a separate classifier obviously for each language. So that's it, brief run through. Here are my many wonderful colleagues without whom this could never have been done. The English and Italian version, Irina, who's currently my RA, coded the electronic MLSE, and these wonderful people volunteered to adapt the MLSE into these languages, a list that is still growing. And we were, of course, not of course by any means, but we were funded generously by the Medical Research Council for this project. I'm happy to take your questions.
Thank you very much, Peter. So we'll start with a couple of online questions, and I'll give them to you both together. So firstly, has the MLSE been validated for single use or as a tool for monitoring changes in language over time? And the second question from Professor Narinder Kapoor, have you validated the MLSE against aphasia batteries such as Boston Diagnostic Aphasia Examination or the Western Aphasia Battery?
Thanks, great questions. Narinder, yes, we used the Boston Diagnostic Aphasia Examination as our gold standard. We ran it in each of the patients in the validation set, in the validation cohort, and we got very good agreement between the relevant domains in the MLSE and the relevant tests on the Boston. So yes, and I probably should have mentioned that. And as to longitudinal, I've run a number of retests on the MLSE in patients with all three classical syndromes, and found a change in all of them, even after as little as 6 months, but mostly the interval's a year. And yes, they do, if there's going to be another question, yes, they do move from one category to another or acquire features that would normally be considered to be characteristic of another syndrome further on in their career, if you like, of which began as a pure variant. Thanks.
Great. Let's have some questions from the floor. So, lady there in the middle. Yeah, thank you.
Thank you. You mentioned classifying the different varieties of PPE and distinguishing them from healthy controls. What about distinguishing from other dementias, particularly Alzheimer's disease? How does it perform there? Yeah,
that's something that needs to be done. I think Alzheimer's definitely does have a linguistic profile. I'm not sure whether it could be. I'm not sure whether it's a unitary one. I mean, we say patients have. Patients with the logopenic variant tend to have underlying Alzheimer's disease, but patients with the more sort of garden variety amnestic onset AD also have language deficits, as we showed in Iris Murdoch, the Iris Murdoch study and the Reagan study. But they probably rather differ from one another. So I don't think we'd get a machine learning model, a decision tree that would say, yes, this is Alzheimer's.
Do you think you would just get something inconclusive out of your decision tree? Wouldn't fall into any of the categories?
Yes, I think in a large number of cases we would. Although, of course, some AD patients present with a progressive non-fluent variant. That's well known, and many of them make semantic errors early in speech. In speech early in the course of their disease. I think, in fact, that Iris fell into that category, and her there was some speculation as to whether she suffered from semantic dementia. So yeah, you could get some. You probably would get crossover. I mean, no clinical method has ever been perfect for determining what the underlying pathology is.
Any more questions?
Hi, I'm just wondering how it handles the effect of anxiety and depression and motivation, etc., especially when it's being used by non-specialist doctors?
Yeah, that's something that comes into all testing, isn't it? And it's part of the skill of the clinician. The good clinician can put somebody at their ease. These aren't difficult tests either. They kind of come naturally. It's not like solving a problem or copying the Ray figure. It's just naming pictures and occasionally making errors. So I think it's fairly immune to those nuisance factors, but it's definitely worth thinking about. I mean, the idea that the patient sitting in front of you and you're marking off, oh, we've made an error there, which we got rid of in the MLSE, is something that that perhaps is also improved by that observation. So thanks.
I'm just looking if there's time for one more question. Gentleman here.
Thanks for the talk. With regards to using language to detect Alzheimer's disease at early stages, I was wondering whether you could just comment on the fact from sort of Brack staging that we know that it affects sort of entorhinal or medial temporal lobe structures earlier than perhaps regions of the brain that are involved in language, and whether you could comment on perhaps the comparative utility of using language compared to more sort of medial temporal lobe focused tasks.
Yeah. That's a really difficult one, obviously a very important one. I think I tried to sort of finesse it when I put that brain up and showed that language was represented very, very widely in the left hemisphere, both frontally and temporally and posteriorly, and with the white matter tracts that are now known to be important. Yeah, I mean, I think the answer is you can. It won't be a uniform profile, but you can detect it. You can detect language change in the presymptomatic, and I suppose that has been shown by the rock curve that came out of the Nervoic deep learning model. There is something different. What it is, we don't know, but or you can't tell, and it's obviously going to be different between each individual speaker. But yeah, no, hope that answers your question. So it's a good one.
Great. Thank you very much, Peter, for getting our opening session off to such a flying start. Thank you.